I'm Peter Johnson. I'm the Professor of Medical Oncology at the University of Southampton, where I lead our program in research in lymphoma.
Dr. Peter Johnson is a frequent contributor to Blood, most recently publishing a plenary paper on lymphoid neoplasia.
We focus particularly on molecular diagnostics and also on functional imaging as a means of optimizing treatment. Primary mediastinal lymphoma is somewhat distinct from the generality of diffuse large B-cell lymphoma. It more often affects young patients, females more than males, and it often presents at an earlier stage because of local compressive symptoms. One of the big dilemmas at the moment for the treatment of primary mediastinal lymphoma is that it is highly curable in initial therapy with a combination of chemotherapy, monoclonal antibody, and consolidation radiotherapy. But we don't know which patients actually require consolidation radiotherapy. We know that there is significant long-term morbidity associated with irradiation of the mediastinum, both in terms of the development of second primary malignancies and also in accelerated coronary artery and valvular heart disease. We would like to get away from widespread irradiation of the mediastinum in primary mediastinal lymphoma because this is a youngish group of patients who have potentially many years of survival ahead of them, given that the cure rates are well above 80% at the moment. We wanted to investigate ways in which we might determine who requires and who doesn't require consolidation radiotherapy after chemotherapy, and for this reason we were investigating functional imaging using FDG-PET. By attempting to stratify at the baseline using functional imaging, we may get a better handle on who requires these different approaches. The approach we took in this case was to look at the FDG-PET characteristics of these primary mediastinal lymphomas and look not simply at whether or not there was a signal, but try and relate the total lesional glycolysis, so the total glucose uptake into the lesion, to the prognosis. And what we found was that even in multivariate analysis, this was highly predictive of the outcome after R-CHOP and chemotherapy. By starting to look at these more sophisticated measures, which are highly prognostic for the outcomes of treatment, I think we can start to stratify our approach much more individually so that we can say to individual patients, you have a very high total lesional glycolysis, we think you should have chemotherapy of the greatest intensity possible, whereas we might say to another one, your TLG is a much lower level, so we think we can take a more straightforward approach to your chemotherapy. Those are the kinds of ideas that I think this study will allow us to start testing in the clinic. From the point of view of patients, we need to run randomized trials, which is what the International Extranodal Lymphoma Study Group is doing at the moment, comparing consolidation radiotherapy with no consolidation for those whose tumors become FDG-PET negative at the end of initial therapy. At the moment, that's about 50% of patients, so we have a study which allows 50% of patients potentially to avoid radiotherapy if we can demonstrate equivalence in that trial. In 5 years' time, we should know the results of our ongoing randomized trial, looking at whether or not we can drop consolidation radiotherapy for patients whose FDG-PET scans become negative after initial chemotherapy for primary mediastinal lymphoma. Following on from that, I'm hoping that we can use the baseline metabolic characteristics of these lymphomas to stratify patients into different approaches to chemotherapy and thereby get the right balance between the morbidity and complexity of the treatment and the optimization of the chances of cure in the long term.
Read more cutting-edge research in the current issue of Blood.